I'm the executive director of the Center for Prisoner Health and Human Rights, which was founded by Dr. Jody Rich. We're based at the Miriam Hospital, and we initiate and support projects and programs that are designed to improve the health and human rights of prisoners through research, education, and advocacy. You can read more about us on our website. You'll see actually some segments of our website on this. Nalini is an extraordinary individual. She's primarily, or initially, an ecologist who pioneered the study of Costa Rican rainforest canopies. She would use mountain climbing equipment to make her ascent, first taking an inventory in 1981 and then doing subsequent inventories later, and understanding and communicating to the rest of the world that there's a whole separate ecosystem that exists at the treetops. And it's actually that ecosystem that nourishes everything below it. Fascinating. You can see her TED Talk, National TED Talk online. I'm actually reading from her fabulous Wikipedia page. One important thing I found really interesting, Nalini and her work in the Costa Rican rainforest were featured in the 1988 PBS series, The Second Voyage of the Mimi, where she was interviewed by like a 12 or 13-year-old Ben Affleck about her work. So she's quite a celebrity, and she's the author of Between Earth and Sky, Our Intimate Connections to Trees, the lead scientific advisor and featured expert in the documentary film series on the truth about trees. She also wrote text for a book for young explorers entitled Kingfisher Voyages, Rainforest, that's published in 2006. Her most recent work, which we'll be hearing a lot more about, has including developing moss growing techniques with prisoners and other scientific work literally inside where she's bringing teaching, helping them to develop skill sets. And out of that has grown her work with the Blue Room, which was featured on the front page of the Washington Post last October about a completely new way of rethinking solitary confinement. So we're looking to work together moving forward to combine correctional health and the work that she's been doing. That's really exciting. So she's an emeritus professor at Evergreen State College and currently professor at the Department of Biology and the director of the Center for Science and Mathematics Education at the University of Utah. She's won many, many awards, including a Guggenheim and an honorary doctorate of science from Brown during the 250th anniversary celebration. So to set the ground for Nalini, I'm gonna talk first about where we are and the landscape that Nalini actually moved into and is changing in so many ways. So this, of course, is the clearest illustration of how scientific term screwed up our system is. That with 5% of the world's population, we have 25% of the world's prisoners. That's totally skewed. And it's a function in many respects of the fact of who we, oops, that's the wrong thing. Okay. This, okay, yes. We need to understand who prisoners are. So they are primarily low-income individuals who are disproportionately non-white, in overall poor health, who come from very, very specific low-income and low-resource neighborhoods. The fact is that their incarceration rates, the high incarceration rates of this population, are a function of the fact that we traditionally have not provided health care for the poor in the country. In other words, Medicaid until 2000, until expansion in January 2014, was limited to individuals with children. The focus was on children, who had children or who were pregnant or who were already disabled. But if you were simply poor and had, say, diabetes, your only option in most communities in the country, and still in many of the states that have not expanded Medicaid, is to receive treatment in the emergency department. Some states, like Rhode Island and the bluer states, tended to have a basic safety net program. But again, for the majority of individuals in the country, and still for the 20 18, 19 states now that have not expanded Medicaid. This is still going to be a fact. Again, illustrating this is that the largest psychiatric facility in every state is going to be that state's largest jail or prison. Every state knows that, talks about it, huge problems that there's more and more of a focus on it, on the challenge. You can just look at some of these numbers, 10% of the general population versus 50% in prisons and 65% or more in prisons and jails who have mental health issues. You can see the significant difference also for the more severe disorders, and understand that these are the individuals who are also primarily going to be ending up in solitary, which we'll be getting to in a minute. Again, the vast majority, and this is a separate subset, but with huge overlap, also have substance use disorders. And of course, we understand now that a substance use disorder is a mental illness. For so long, they have been treated separately, and that is, thank God, beginning to change. Nevertheless, the highest recidivism rates for any institution in the country are among individuals who have co-occurring mental health and substance use disorders. So again, you can see the numbers here versus numbers in prisons and jails. One key thing that must always be remembered when we're discussing the criminal justice system is that there is an inherently, there's a racial component, racial disparities that are unexplainable except by essentially, ultimately racism at different levels of the system. It's just impossible to understand in any other way. You can see some of the ridiculous numbers here, ridiculous but very real, and what we need to be addressing. You can see in particular that until the advent after the advent of the war on drugs, once that began going, that huge gap between the number of people in the country and the percentage of prisoners that we have, much of it is defined by that top line, which are black individuals who were incarcerated because of drug issues. Obviously, the war on drugs, the criminalization of mental health disorders contributed to this huge disparity and affected primarily populations of color, low-income populations of color that had no other resources in many parts of the country. And again, still to this day, the only option for a low-income individual with a substance use disorder for treatment is going to be in the local jail. So, in fact, Medicaid didn't even cover, was not required to cover behavioral health treatments, mental health illnesses, or substance use treatment prior to 2008 at all. Some states did that, not a requirement. So even individuals who might have had Medicaid would not necessarily be able to be treated in their own communities. Huge issue where they end up inside our prisons and jails. You saw those initial numbers. The population is low income. They suffer from the same higher preponderance of infectious and chronic diseases that low-income populations do. Again, they're not getting treated, or they hadn't been historically getting treatment in the community. Rates of HIV/AIDS are 4 to 5 times the rate in the general population. Hep C, 9 to 10 times the rate in the general population. TB, 17 times. We can go through the list of every, diabetes, asthma, hypertension. The diseases of the poor are concentrated in this population in incredibly disproportionate amounts. So this is what defines the population is first, income, low income, second, race, third, poor health. And for anyone in public health or community health, those are overlapping distinctions that are mutually reinforcing as well. What this means also is that prisons and jails present an unfortunate but real public health opportunity. Obviously unfortunate, individuals should be getting treatment in communities, not inside. So, but what's been happening is that there is a huge and growing movement, I won't say huge, a growing movement in the country to change the ways that this is done. And it's led among other individuals by people like Newt Gingrich, who in 2011 co-penned a very important op-ed in the Washington Post, announcing the advent of the Right on Crime organization that was headed by some of the most, by the very, very, very extreme right wing individuals, from Grover Norquist to Ed Meese, individuals who have been architects of the problem, who recognize that we can no longer afford business as usual with prisons. The criminal justice today is broken, and conservatives have to lead the way to fix it. This means what we're talking about is a movement that is happening across the political spectrum. And this is actually exciting. Again, Nalini and I were talking earlier. Their motivation is for the most part, financial. States budgets are broken. The biggest part of that deficit is caused by correctional health and law enforcement expenditures, particularly around correctional health, where 100% of, for instance, health costs have to be borne by the local prison or jail. Reform is also happening in other places within the system. Solitary confinement has become a huge issue, recognized by Justice Kennedy in his dissent. Anyway, recognized by Justice Kennedy in one of his co-occurring opinions, who was essentially inviting a case to the Supreme Court challenging the use of solitary. And there is a growing political movement around that, which we'll get into a little bit more. One thing I want to mention also, to be remembered by those of us who are championing the reform movement and doing business and getting more individuals into treatment in prisons and in the community, is that we have a huge gap in capacity in the community. In other words, we need individuals to get into treatment, mental health treatment, and substance use treatment in the community. The capacity is lagging woefully. I could go into examples of that, but one of the things we need to be pressing our legislators to do is increasing funding, for instance, for mental health community providers, which have been cut consistently across the board and across the country as Medicaid expansion grew. Critical to remember, and something that must accompany any meaningful reform efforts, is the need to increase, not maintain, to increase capacity in the communities. So this is a shot of behavior of one of the challenges of, and who ends up in solitary, are individuals primarily who cannot obey orders. That's where they are sent to solitary. Meaning that generally prison populations, 15% of the general population have serious mental health issues. Not surprisingly, we saw those numbers earlier. By the time you get to maximum security prisons and the highest security levels, 50% or more of the population is seriously mentally ill. Obviously, individuals can't follow orders, they're off their meds, they're given the wrong meds, they're all any number of contributors to that phenomenon. Nevertheless, the bottom line is poorly treated mental health means you're either acting out, you're disobeying orders, you tend to spiral up the system through the security levels. So this is a maximum security prison. This is how therapy is provided. Walking door to door so that anybody can hear, checking in with the individuals who are incarcerated behind them 23 out of 24 hours a day, 7 days a week, sometimes for years. So there's been a huge pushback on that, obviously. This is one improvement was things like, here's group therapy in solitary. Lots and lots of pictures like this, but just to give you an idea of the negative reinforcement that many prison systems have that are beginning to address it, beginning to address the challenge. President Obama was the first president to visit a prison, was it ever? And talk specifically about solitary and the challenges that are there. the Supreme Court has held and made significant movement, and it's happening in legislatures as well, around the juveniles who are mentally ill, and beginning to look more and more at individuals with mental illness, but nothing has happened yet. So the excitement, though, is that there are other forces that are helping to change the discussion around solitary in the country. Last month, I went with Director E.T. Wall of the Rhode Island Department of Corrections to attend. We actually brought him, it was so important, on prolonged solitary confinement, which had experts from around the world. The key take-homes, and I'll walk through a few of them very, very briefly, is that if we're really looking at viable prison reform, what is critical, what is really critical, is culture change. In other words, closing down solitary or shutting down solitary is excellent. But if the circumstances into which individuals who either have been acting out or have mental health problems has not changed, it's virtually impossible to have significant change. So the other exciting development, and I never thought it would happen as recently as 10 months ago when Jody Rich told me about this, was that more and more we are turning to European correctional systems as models based on their lower recidivism rates, extraordinarily lower recidivism rates, that are rooted in more humane treatment and principles of normalization. In other words, and this was it was so powerful to see in Pittsburgh, was groups have been sent, are being sent to Norway to actually observe, to spend a week in the prison. Some of you were here for Ari Høydal's, Warden Ari Høydal from Halden prison in Norway, who talked about the differences between the prison systems and laid the groundwork for how systems that have visited Norway are coming back and actually making significant, substantial changes. The director of the North Dakota prison system, who went last September, March, anyway, last year, came and did a presentation, and this was her title slide. And this alone speaks to the difference in attitude that has to accompany any meaningful change. Humanity in North Dakota, learning from Norway to make better neighbors, not better prisoners. The significance of that seemingly semiotic change is huge. This is my neighbor. You know, we have done the best we can to ostracize the ultimate other, the criminal, the prisoner, and to shift that focus is what needs to be happening, and it is, in places like North Dakota, in places like Colorado, where the last director of the Department of Corrections was murdered by an individual who had been in solitary confinement for 15 years and was released directly to the street. Within a week, he went and found the head. It was a horrible, horrible incident. But it shook them up so significantly that they actually have been changing solitary there, to follow some of these examples that we've been seeing. So there are multiple sources and influences and factors that are pushing us in this direction of reform. I just want to look at a couple more. These are the differences between the Norway maximum security prison and the North Dakota prison. Obviously not surprising. Well, surprising on that side of the screen. Very exciting. Not going to happen tomorrow. But there are things that can happen, like letting men and women wear their regular clothes. Just changing a lot of the attitudes. Leanne Birch, the director, talked about all of the usual build-ups and horrors that were happening in the system, and then they went to Norway. The take-homes that she got were these, and I'll just talk about two. The importance of focusing on the human being, not just criminogenic risk and need. Again, this is it was mind-boggling, and people were nodding. I was sitting next to the head of the Florida Department of Corrections, which is under, I can't tell you how many lawsuits based on poor provision of health care inside, taking notes. A.T. Wall came back with a full pad of notes on this wall, saying that he had the evidence that he needed to go and really effect real change. This one down here, empower staff from the lowest level to make decisions and to view their role as change agents. As Director Rick Ramish said from Colorado in talking about this, our correctional officers need to be more like social workers. This is mind-boggling. I'm Sir Barrier sitting back there. He's the second in command of the Department of Corrections. We're talking huge potential shifts and huge resources that are going to be needed. The average training in Norway to be a CO in Norway is 2 years for a correctional officer. It's 9 weeks, 10 weeks on average across the country. The skill sets that need to be imparted are huge and beginning to happen in North Dakota as a result of that visit. They made some significant changes to solitary. Behavior way in will help you behavior way out. This was one thing that was also really important to understand. If we want to change solitary, there are other things that need to happen. Training staff to act more like social workers, as I mentioned, is critical. Crisis intervention teams are needed inside. In other words, we're talking about diversions to keep mentally ill individuals out of the criminal justice system to start with. But if we're going to be keeping more individuals with potential problems inside, we need the skill sets to deal with that. Somebody acts out, the crisis team goes in, de-escalates. We have a much safer situation on hand, and somebody whose mental illness or whatever the challenge is being dealt with as it should be, not as a purely disciplinary infraction. Residential treatment units. Again, we cannot simply abolish solitary without having places for the individuals with serious mental health needs who are acting out to go. So, staff perceptions. These really blew me away. These are from staff comments that were made in a follow-up survey after several months of this shift in the way that they were doing solitary. You know, I hope this works because this is a lot more fun to work down here like this. I was skeptical, but it felt really good when this guy did his skill practice with me. It worked. I'm actually starting to practice some of the skills in my own life. These are COs talking. You have to understand what the profession with the highest suicide rate, the highest divorce rate in the country are correctional officers. This is not a necessarily easy or fun job. The stress passes back and forth. This individual got into corrections. He wanted to make a difference. The prison system he came from instead taught me to see inmates and treat them like shit. As a result, there was constant violence. Since working on this, the Change of Segregation project, I feel like I'm actually making a difference. I did not realize how much trauma and depression I was carrying around because of my work. I know that we are healing them with these interactions, but what I did not expect that it is healing me too. These are the points of sale for when we want to bring this to the leaders of correctional institutions around. So we're rehabilitating people, not just locking them up and hoping they don't do the same thing again. So exciting things happen. We've been invited to form a delegation to go to Norway this fall. That's funded by a California NGO. Two other important things that we're going to hear a lot more about right now with our special guest. Normalization. A key factor of what they're trying to do in Norway, now what they're doing in North Dakota. How do we normalize the way that we deal with the individuals who are incarcerated, who are locking up? We need more programs, more partnerships in the community. We need to make our prisons more like schools. Our schools also more like, less like prisons, but where we're providing education, providing skill sets, providing acceptance, being more human. We also need to approach how we actually do solitary. When we put someone in solitary, there's a really different way that we can do it, which will make so much sense when we hear about it.